Hi, my name is Sharon Chen, and I am a pediatric infectious disease physician at Stanford University. This video is about measles virus, the clinical characteristics of measles infection, and its prevention with immunization. The learning objectives are to describe measles virus, its infection cycle and interaction with host immunity, to recognize the clinical signs and symptoms of measles infection, and to explain the diagnosis, treatment, and prevention of measles infection. Here's our pathogen list. As you can see, measles is an RNA virus, and in this phylogenetic tree, you can see it is related to parainfluenza virus and RSV. Now, in the U.S., we don't see measles infection on a regular basis, so I want to give you some general concepts to illustrate its significant impact worldwide. It's an infection that hits infants and young children the hardest, and worldwide, measles is one of the most important causes of child morbidity and mortality. Before widespread immunization began in 1980, there were 2.6 million deaths per year. Most of these were babies and young children. With some, but not complete measles immunization globally, there are still about 145,000 deaths, that's 14 deaths an hour, of mostly young children less than 5 years old in 2013. All of these deaths can be prevented. A safe and effective vaccine is available, but not used universally throughout the world. Universal immunization is challenging because of logistical and financial issues in countries where measles is endemic and because of objections to measles immunization in countries where measles has been controlled. Immunization is the best strategy for measles control because there are no effective antiviral medications for treatment, and measles is a highly contagious virus. 9 out of 10 susceptible people exposed to a measles-infected person will develop measles. Measles virus is a paramyxovirus that likely evolved from rinderpest virus, another paramyxovirus that wiped out entire herds of cattle, as you can see in the pictures. But rinderpest virus is now completely eradicated with universal immunization of cattle. Measles virus is human-specific. You can see in the figure that paramyxovirus family includes many respiratory viruses like RSV, parainfluenza, and metapneumovirus. In fact, you can think of measles as a respiratory virus, but in contrast to the other ones, measles always causes a systemic illness. Like the other paramyxovirus, it's enveloped with an RNA genome. It has 2 glycoproteins, F, fusion, and H, hemagglutinin proteins, that are important for attachment and entry into host cells. There is only one antigenic type. You can also see in the diagram that mumps is a paramyxovirus. Mumps virus is transmitted via respiratory secretions and classically causes parotid swelling. About a third of patients are asymptomatic or have mild respiratory symptoms. There's a vaccine for mumps, and typically it's given together with measles and rubella vaccine. Now I want to go through the infection cycle for measles using our microbiology life cycle framework. After being exposed to infected respiratory droplets or aerosolized small droplet nuclei, measles virus enters the upper respiratory tract and experimentally can start infection anywhere along the tract from the nose to the lower airways. I told you before that measles virus causes a systemic illness. So how does measles virus disseminate from the respiratory tract to the rest of the body? Initially, measles virus interacts with 2 different cells in the respiratory tract. Along the mucociliary epithelium, dendritic cells can poke through the junction to pull in measles virus from the lumen. Measles virus uses glycoproteins H and F to attach to specific dendritic cell receptors. In the alveolar space, patrolling alveolar macrophages in the lungs can be infected with measles virus. The end result is that both the infected macrophage and the dendritic cell transport measles virus to local lymph nodes where they now infect lymphocytes, T and B cells, and replicate, making many more measles viruses. The infected lymphocytes use the lymphatic system to disseminate measles virus to other lymphoid organs, like the spleen and tonsils. Infected lymphocytes don't just disseminate measles virus to lymphoid organs, but also to other organs, including the intestine, skin, and back to the respiratory tract, among many others. Measles virus can infect epithelial and endothelial cells at these organs. Now, as you can see, I've been talking about measles virus infecting and replicating in immune cells rather than being killed by them. What's going on? Measles virus is able to subvert the innate immune response, including inhibiting toll-like receptor signaling and inhibiting the synthesis and signaling of interferons, a major antiviral immune response. Measles virus can also suppress adaptive immunity. Infecting lymphocytes can result in decreased numbers of lymphocytes called lymphopenia. Measles virus can interfere with antigen presentation to T cells and interfere with activation signaling pathways, all resulting in T cells that are not effectively activated against measles virus. Measles infection has been associated with a transient immunosuppression, likely from some of the mechanisms that I just mentioned. Now, to complete the life cycle, measles virus needs to exit the host. How does it do this? Measles virus is disseminated back to the respiratory tract, where it enters respiratory epithelial cells from the basolateral side of the cell. Measles virus uses its glycoproteins to attach to specific host receptors in the junction between epithelial cells. It can then replicate within the cell and exits the cell on the apical side by budding. The damaged epithelial cells causes irritation, and measles virus is expelled by the host through coughing and sneezing. This exit strategy is likely what contributes to the extreme contagiousness of measles infection. Now, let's discuss the clinical signs and symptoms you will see that are associated with the measles infection cycle that I just described. The process of measles virus entering a person, replicating in lymph nodes, disseminating to lymphoid and other organs is all occurring with no clinical signs and symptoms in the patient. This is called the incubation period, and it lasts for around 10 to 14 days. Around the 14th day after exposure, you can start to see clinical signs and symptoms. First comes low-grade fever with a little bit of malaise. Then you start seeing the classic signs and symptoms of measles: cough, coryza, which is a bad runny nose and congestion, and conjunctivitis, which is inflammation of the conjunctiva. These signs and symptoms represent the prodrome phase and are present before the rash. The first rash that is seen after the prodrome phase is actually an enanthem, which are lesions on mucosal surfaces. These are called Koplik spots when associated with measles infection. They are white, bluish specks on a bright red mucosal surface, typically on the buccal mucosa or on the lower labial mucosa. You can see a picture of this in the photo. Koplik spots appear a couple of days before the skin rash and have mostly resolved by the time the skin rash is apparent. So practically speaking, you may never see these in clinical practice. Now, 4 days after symptoms start, the skin rash or the exanthem appears. I'll describe this in more detail in a later slide. The onset of the skin rash coincides with activated T cell immunity against measles virus, finally controlling measles replication. After a day or two of the skin rash, it's very difficult to isolate replicating measles virus from patient samples. So basically, once the rash starts, many of the clinical signs and symptoms begin to resolve. By the 3rd or 4th day of the rash, the fever, coryza, and conjunctivitis have resolved. Cough, however, can last for a couple of weeks. All right, so what about measles rash? The rash looks red with a maculopapular pattern, which can then coalesce, that means group together, especially on the face. The picture of the baby shows you the classic appearance after about 3 days. Measles exanthem has a characteristic pattern of appearance. It begins first on the forehead at the hairline and behind the ears. It then spreads to the trunk and extremities over a couple of days. After 3 to 4 days of rash, it begins to clear, and during this time, the rash takes on a coppery appearance with a brownish discoloration. The rash resolves in the same pattern, first the head, then downwards. Total duration of the rash is around 7 days. The other clinical signs and symptoms are seen when the rash appears. Fever peaks on day 2 or 3 of the rash and then resolves around day 3 or 4 of the rash with resolution of coryza and conjunctivitis. So what exactly causes this rash? Well, we don't really know. It could be from infection of the keratinocytes or from the T cell response to measles virus replication in the endothelial and epithelial cells of the skin. Now, there are other clinical signs and symptoms that can be seen. Just think about the organs that measles virus disseminates to. Infection of the intestinal epithelial cells leads to diarrhea, vomiting, and abdominal pain. Dissemination to lymphoid organs results in cervical lymphadenopathy and splenomegaly. Pharyngitis, viral pneumonia, and bronchiolitis can occur with dissemination to the mucosal epithelium of the upper and lower respiratory tract. More unusual is encephalitis. Secondary bacterial infections is a major complication of measles infection. It is partly due to the transient immunosuppression that I mentioned before in the measles virus life cycle. Pneumonia is prominent and is the cause of 60% of deaths in infants. Otitis media is also common, and really essentially any other part of the upper respiratory tract can manifest a bacterial infection, for example, tracheitis or pharyngitis. In developing countries, pneumonia and diarrhea after measles infection are a source of morbidity and death. A second important complication of measles is SSPE, and it stands for subacute sclerosing panencephalitis. SSPE is very uncommon compared to secondary bacterial infections. It's a slow, progressive CNS disease that's usually fatal. It occurs 4 to 8 years after acute measles infection, and a prominent risk factor is acquiring measles infection before age 2. Measles is known to be the causative agent of SSPE, but the mechanism that results in SSPE is not definitively known. Measles infection is mostly a clinical diagnosis by its prodrome, symptoms, and exanthem. If laboratory testing is necessary, a positive measles IgM antibody is diagnostic. So is a fourfold rise in the measles IgG titer comparing acute versus convalescent testing. Molecular assays like PCR are available, but usually through public health labs. Same with cultures. Wild-type measles virus grows much slower in culture compared to laboratory strains. Please remember, you must report measles infection to the public health department. Remember, measles is very contagious and poses a very large public health problem. There is no effective antiviral treatment for measles. You give supportive care. In developing countries, vitamin A is routinely given to patients to decrease mortality, especially from pneumonia. In the U.S., select populations should be given vitamin A. As I said before, all the complications, deaths, and morbidity from measles infection can be prevented. A vaccine is available. It is a live attenuated vaccine, which means that a live but very weakened virus is used to stimulate the immune system to develop an anti-measles immunity. Measles vaccine is usually combined with mumps and rubella vaccine and is called MMR. It is very effective, 95% efficacy with 1 dose, increasing to 99% with the recommended 2 doses. You can see in the figure the plummeting of measles cases once measles vaccine was licensed and used in the U.S. The resurgence in the 1990s was due to a drop in immunization rates for young children. Measles immunization is also effective at decreasing mortality from measles. A 75% drop in deaths occurred with about a 10% increase in the world's children receiving 1 dose of measles vaccine. Now, people traveling to areas with endemic measles can be infected and bring measles infection home, potentially starting an outbreak. Outbreaks can be prevented if the local community maintains at least a 93% measles vaccination rate. If it's lower, then measles virus can begin circulating and infecting susceptible people. You can see in the figure that in 2014, measles cases increased dramatically in the U.S. About 300 of these cases were in Amish communities in Ohio among the unimmunized. A measles-infected missionary had returned to Ohio from the Philippines, where there was a very large outbreak of measles. So I hope I have convinced you that measles vaccine is very important.